Welcome to another episode of the Thyroid Stimulating Podcast, which is created in conjunction with the American Thyroid Association to discuss up-to-date diagnosis and management of thyroid diseases. I'm your host. Our thyroid gland plays a crucial role in regulating many bodily functions, including metabolism, energy levels, and even our sleep patterns. Whether you're dealing with hypothyroidism, hyperthyroidism, or simply curious about how this small thyroid gland impacts your nightly rest, this episode is for you. We'll explore how thyroid imbalances can lead to sleep disturbances such as insomnia and how poor sleep quality can impact your thyroid gland. Joining us today is Dr. Skand Shekhar from the NIH. He completed his medical school at the University of Delhi in India and completed a Master's of Health Sciences from Duke University School of Medicine, and went on to complete a clinical and research training and an endocrinology fellowship at the NIH, focusing on reproductive endocrinology. His research involves studying the interaction between lifestyle, sleep, diet, and the hypothalamic pituitary gonadal HPA axis in humans. He is developing clinical trials to enhance our understanding of sleep, metabolism, and reproductive endocrinology interplays. And he's here today to discuss the interactions between the thyroid gland and your sleep.
Thank you. Thank you very much, Kaniksha, Dr. Desai, for inviting me to your podcast. I'm very happy to be here, excited to talk to you about this important topic. And before we move any further, I do want to clarify that everything I say today reflect my personal views, and I do not speak on behalf of the NIH or the U.S. federal government.
Okay, thank you so much. Well, how did you get interested in this topic?
That's a good question. I have a deep-rooted interest in neuroendocrinology and its interaction with our environment. And inevitably, sleep is at the center of this interaction, which integrates things like onset of puberty, growth hormone secretion, and of course, a number of metabolic disorders that tend to have an association with sleep. Therefore, it was natural to think about thyroid and how it is related to sleep, which really sparked my attention. In addition, from a clinical practice standpoint, we also see a lot of patients who have thyroid problems tend to also complain of sleep issues. So it was just a natural subject that piqued our attention, and we decided to delve deeper into this topic.
Yeah, so speaking of that, I know a lot of thyroid patients have sleep problems, and a lot of sleep problems can cause thyroid problems. So how common of an issue is this?
It's actually a fairly common issue, and I'll try to answer this question by breaking it up into individual issues. Firstly, as far as hypothyroidism is concerned, it's a widely prevalent issue. In fact, the NANS data that was published a few years ago demonstrated a steady increase in the rates of hypothyroidism, such that it has doubled from the estimate of about 5% in the late 90s to approximately 10% in 2019. And it tends to impact women disproportionately. Similarly, hyperthyroidism is also a common problem, although not as common as hypothyroidism, and it affects about 1% of the general population. Again, women are more widely impacted. In terms of sleep problems, the CDC has released data that indicates that 15% of the adult population tends to be impacted with one or more sleep problems. And that, again, tends to be more common in women, where about 17% of women have sleep problems compared to 11% men. As far as the overlap of both these problems is concerned, there's not a tremendous amount of data. Whatever data is sort of indirect. But there was one important study that showed that 1 in every 4 people who had hypothyroidism were affected by obstructive sleep apnea. Similarly, there is no reason to believe that sleep problems would be any less common in patients who have hyperthyroidism, and certainly those of us who see patients with hyperthyroidism, we could attest to this issue. So it's clearly an important issue, affects a significant percentage of our patients.
Yeah, so speaking of that, I wanted to get into the physiology and the pathophysiology behind that. So, what are some of the underlying mechanisms by which thyroid hormones influence sleep patterns and sleep quality?
Let's start with circadian clocks. So, circadian clocks are internal timekeeping mechanisms that regulate many physiological functions in humans. These endogenous clocks are integrated at the level of the suprachiasmatic nucleus and the pineal body, and they create oscillations for a 24-hour period, which is what we call the circadian rhythm. Thyroid hormone secretion has a distinct daily rhythm, and it is heavily influenced by the circadian rhythm, such that TSH has a distinct day-night pattern. So, as an example, TSH levels are the lowest between 3 o'clock in the afternoon and 7 o'clock in the evening, and they tend to be the highest between 11 p.m. and 5 a.m. For circulating thyroid hormones, the data are a little bit less clear, but the most robust studies that have been done to date by Gunderson and colleagues and Russell and colleagues have demonstrated, again, a clear diurnal circadian pattern of T3 and T4 secretion, such that free T3 rises by about 15% and free T4 rises by about 11% at nighttime. It's also interesting to note, but not that surprising, that these peaks tend to be shortly after the peak of TSH, and there's a time lapse of about 90 minutes or so. In terms of the interrelationship between sleep and thyroid hormone secretion, multiple studies have demonstrated that there is a close relationship, which is partly influenced by the circadian rhythm, but it's also independent of that rhythm. To give you an example, restful sleep, or what is called the slow wave sleep, decreases the amplitude of circadian TSH secretion and also of circulating active thyroid hormones. It has been suggested that lower TSH and thyroid hormones in turn are permissive for what is called slow wave sleep or restful sleep and maintenance of normal sleep architecture. I think it is safe to say that sleep quality and architecture also influence TSH secretion, and this association tends to be bidirectional, such that decreased slow wave sleep can negatively impact thyroid hormone secretion and vice versa. Talking a little bit more about the active thyroid hormone, namely free T4, it has been proposed that the widely reported increase in T4 levels in response to energy to sleep deprivation are actually a physiological adaptive mechanism. Thyroid hormones tend to upregulate mitochondrial numbers and also increase their function. And this is through thyroid hormone receptors present in neural mitochondrial membranes. And so one could easily understand that in the setting of increased energy demand, there is an increase in the number of mitochondria, which is able to produce extreme levels of ATP that can keep up with that neuronal energy demand. And the final piece of this puzzle is dopamine. Many of you in the audience may already know that dopamine inhibits prolactin secretion and also inhibits TSH and thyroid hormone secretion. On the other hand, dopamine is important for sleep regulation and is actually promoting sleep. So, good evidence for dopamine as being intermediary in the sleep-thyroid interaction comes from studies of restless leg syndrome, where there's actually a decrease in dopamine tone and an increase in kinetic activity, which has also been associated with states of excess thyroid hormone. So it's a complex interrelationship interacting at multiple levels, but both sleep and thyroid hormone function depend on each other.
Thank you for that description. Can you go a little bit into how the different sleep stages are affected by the thyroid gland? We'll quickly review the sleep stages and how they're impacted, and if there's specific sleep stages that are impacted.
Absolutely. So as many people may already know, sleep consists of two phases. One is what is called the non-rapid eye movement stage of sleep, and the other is the rapid eye movement of sleep. And within the non-rapid eye movement, there are three stages: stage 1, stage 2, and stage 3, also known as N1, N2, and N3. N3 corresponds with the slowest waves of EEG activity, and it also is known as slow wave sleep, and it corresponds to the most restful sleep that we experience. Now, taken together, NREM and REM are anywhere between 70 to 90 minutes or one cycle, and multiple such cycles occur over the course of the night. So it's important to understand that slow wave sleep is the most important element of sleep that actually helps promote restfulness and energy. As far as your question about specific stages of sleep are concerned, as I alluded to earlier, N3 is the most important stage of sleep from a resting standpoint. And unfortunately, regardless of a thyroid hormone excess, which is seen in hyperthyroidism, or a thyroid hormone deficiency seen in hypothyroidism, N3 tends to be the most impacted. There are other elements of sleep, such as sleep architecture, which includes total sleep duration, sleep latency, number of awakenings, and many other elements. But what is the data is most clear about N3 being negatively impacted by thyroid hormone imbalances.
Can you talk about or differentiate how hypothyroidism and hyperthyroidism are different for our listeners?
Yes, I'm happy to. So, hypothyroidism is a state of inadequate circulating thyroid hormones, and it occurs due to a number of different reasons, which I'm not going to go into too deeply. But I'll give you an example. There was a study conducted on 30 hypothyroid patients where there was an increase in N1 and N2 and a decrease in N3 and rapid eye movement sleep compared to controls. But there was no change in sleep duration. So again, this was one of the initial studies that indicated a decrease in restful or slow wave or N3 sleep. Similarly, there was a recently published analysis of the NHANES data, which is the national database here in the US, that concluded that increased sleep duration was related to decreased T3 levels. However, this association was only significant till subjects reached a threshold of 7 hours or more of total sleep duration. And after reaching that 7 hours of sleep, this relationship was no longer significant. In other studies, patients who have hypothyroidism also have been shown to have an increase in the number of awakenings at nighttime, meaning they have to wake up, or there are micro arousals overnight, and a reduction in slow wave sleep that occurs consistently. And various mechanisms have been proposed, but a paucity of active thyroid hormones tends to be the most important element which is driving this.
Okay, so that's a lot of information for our listeners. I actually wanted to help kind of distill it down. So how do you differentiate between sleep problems caused by thyroid issues versus other sleep disorders? And should patients with sleep disorders get screened for thyroid problems? What would be the benefit of that?
Unfortunately, there is no great clinical way to do that. And the best way to do that would be to screen for thyroid function and thyroid dysfunction by blood tests. I do think that it's important to also consider the specific circumstance of a patient who comes to you in the clinic. So, for instance, if we have someone in the clinic who's reporting daytime sleepiness, fatigue, cold intolerance, and weight gain, I think it's a no-brainer. You should go ahead and order thyroid screening. But if somebody only has isolated sleep problems and they don't have other risk factors or other complaints that indicate thyroid dysfunction, it's probably important to consider other primary sleep problems. But I still think that it may be reasonable to screen for thyroid dysfunction on a case-to-case basis. So, the most important thing is to have a low index of suspicion, perform simple screening with blood tests in these patients.
So say you found somebody was hypothyroid or hyperthyroid. Um, how long does it take for sleep patterns to kind of improve after starting either levothyroxine or treatment for hyperthyroidism with methimazole or radioactive iodine or surgery? What is the expected time for improvement on that end?
Right. There is not too much data that has actually been published in terms of the timeline um, for recovery of sleep and treatment of these conditions. But I will cite maybe one study which actually uh, was was able to demonstrate that there was subjective improvement in the quality of life of patients a few weeks after initiation of levothyroxine in patients who had hypothyroidism. I think more than really setting sort of community standards, what I would probably suggest to most patients is that improvement in symptoms, especially if you have hypothyroidism, can take weeks, in some cases, even months. And sleep dysfunction will also improve along that same timeline. Now, if after a few weeks of treatment, they are not experiencing relief, they're snoring, they have sleep apnea, they have other kind of conditions. And I think in those circumstances, the or the first task of the endocrinologist is to assess whether the treatment is even working, because it may be possible that they may be under replaced or they're not absorbing or they're not taking the medication. But if we've ensured that those elements are not at play, then I think it's quite reasonable to recommend that these patients undergo specialized sleep assessment, because there may be some other primary sleep disorder underlying their thyroid dysfunction. So I think it has to be again monitored over time, but few weeks there should be some response in most patients.
So speaking of that, can thyroid hormone themselves cause, like levothyroxine, cause any sleep disturbances? And my patients often ask me, is there an optimal time of day to take your thyroid medication to minimize any sort of sleep disruption?
Unfortunately, again, this is an area which has not been as deeply studied as we would like it to be. But I'll point you to one study published out of the Netherlands by Polk and colleagues in 2010, which compared thyroid function tests and clinical outcomes such as lipid values and quality of life measures, which included fatigue scores in patients who were taking levothyroxine at bedtime versus levothyroxine first thing in the morning. In both conditions, patients were supposed to be taking them empty stomachs, meaning there was some gap between their previous meal and intake of levothyroxine. What authors found was that there was no difference in quality of life measures between those who were taking these medications at bedtime versus in the morning. And this included things like quality of life measures and fatigue scores. While sleep was not directly addressed in the study, I think there is adequate reason to believe that uh, sleep measures would also be equally treated, whether the patient takes it in the morning or takes it at bedtime. But the key is to take it on an empty stomach, especially in the case of levothyroxine, and follow the other instructions that come with it. But timing of day doesn't tend to be a major factor. As far as antithyroid medications are concerned, they're usually taken 2 to 3 times a day initially. And most prescribers will end up prescribing once a day when it comes to maintenance dosing. There's not any report on them being directly responsible for any sleep disturbances, which is good news.
That is good news. Okay, so in summary, it doesn't really make a huge impact on what time of day you're taking your thyroid hormone, as long as you're taking it on the empty stomach and waiting an appropriate amount of time to take food and medications.
Exactly.
I actually wanted to switch topics a little bit. We talked a lot about the hyperthyroidism and hypothyroidism, but conversely, I wanted to kind of talk about how sleeping and the amount of sleep that you get and the quality of sleep that you get can impact your thyroid gland.
That's an important question. And I think we touched upon it very briefly earlier, but what has been shown is that sleep disruption tends to alter thyroid physiology. So some studies that come to mind are studies of sleep disruption and performing frequent thyroid hormone assessments. And what multiple studies, which are most of them are actually published from the 90s and early 2000s, have shown is that those who have sleep disruption or restricted sleep, they have, in many cases, decreased levels of circulating thyroid hormones. And that tends to be an adaptive mechanism because their neurons require more energy and more mitochondria need to fire. So there tends to be that increased thyroid hormone secretion. And by contrast, there tends to be a decrease in TSH amplitudes at bedtime. In other words, one could extrapolate and say that sleep restriction tends to be associated with subclinical forms of hyperthyroidism as an adaptive mechanism.
And I think you briefly covered it that if you're getting less than 7 hours of sleep, your T3 levels decrease, or one particular study had shown that.
That's exactly right. And that was data from NHANES. So I think from a very clinical standpoint and practical terms, ensuring healthy amounts of sleep, making sure that it's good sleep hygiene, and some of the other measures that tend to be associated with good sleep can go a long way in restoring thyroid physiology.
Can you just quickly review those, like 8 hours of sleep, and what are some of the other recommendations that you have to help alleviate patients can improve their sleep quality?
Oh, absolutely. I think the most important element, which unfortunately is not adequately emphasized, is the importance of what is called sleep hygiene. So in general, it is recommended that most adults will require anywhere between 7 to 9 hours of sleep, and it has to be uninterrupted for them to be at their optimal capacity. Some of the lifestyle measures that can really assist with adequate sleep, or I'll start with room temperature. So it's very important that patients make sure that their room temperature is at a comfortable level. Most patients will set a temperature between 65 to 70 degrees Fahrenheit, and it may be somewhat different in patients who have thyroid dysfunction because there may be cold intolerance or heat intolerance, and so you have to individualize that temperature based on their clinical status. For example, going to bed at the same time every day and waking up regardless of it being a weekday or a weekend, avoiding the use of electronic devices, especially close to bedtime. I'm sure not a lot of people are following that, but it is what it is. There's also the issue of the mattress being comfortable, making sure that the environment of the room is cool, dark, noise levels are kept to a minimum. Doing daily exercise, that can help a lot. So especially about 4 to 6 hours prior to their bedtime, it is recommended that patients engage in some activity. And importantly, not eating heavy meals right before bedtime. If people are hungry, they can have a light snack, and avoiding caffeine and alcohol right before bedtime. I think these are simple measures, but they can go a long way in ensuring that patients get restorative sleep.
Okay, so there you have it. Important sleep habits for you to work on to improve your thyroid health. You talked a lot about thyroid disorders are more common in women, but is there different aspects if you have special populations such as children or elderly or pregnant women?
Sometimes they will just manifest with GI symptoms or having a high heart rate or some non-specific symptoms, but they'll also complain of sleep problems. So I think a lot of these patients do get missed. I'm pretty sure that we are missing some of these patients because they have non-specific symptoms. So keeping a low threshold for assessing thyroid function. There is a distinct element called apathetic hyperthyroidism in elderly patients where they just have one isolated issue. So again, keeping a low threshold when they are complaining of something is important. Unfortunately, there's also a rise with age in the incidence of sleep disturbance. So there tends to be a double hit. If there is an underlying thyroid problem and there is an aging individual, that tends to be a double hit on their sleep cycle, which can sometimes worsen outcomes. So there has to be some special attention. As far as pregnant women are concerned, again, sleep tends to be affected by a range of issues, independent of thyroid function first. So things like having to wake up in the middle of the night multiple times to go to the bathroom, having aches and pains, having gastroesophageal reflux disease, having back pain. All those things can really impact their ability to have restorative sleep. In addition, as your audience may know already, there is a high burden of thyroid dysfunction during pregnancy. So hypothyroidism tends to be worsened because of increased demand. On the other extreme is hyperthyroidism, where an entity like hyperemesis gravidarum can both lead to nausea, but also lead to hyperthyroidism and also impact sleep. In fact, one study found that almost 2/3 of patients who had hyperemesis gravidarum had sleep disruption, and that tends to also go along with hyperthyroidism. And then finally, there is also some association between restless leg syndrome that can occur in pregnancy and thyroid dysfunction. So again, it's complicated to put it in one sentence, but I think screening these special populations is very important. And last sentence about children is that they also tend to have similar symptoms like adults, but sleep is also important for their growth. So if sleep is not adequate, especially during important parts of pubertal development, their growth can be negatively impacted. So it's important to, again, keep in mind those finer details when dealing with these patients.
So I know you touched on this earlier. There isn't a lot of research done in this topic. Is there emerging research or therapies, treatment options that may be coming out where you just recommended those lifestyle changes?
The first and foremost thing is to individualize the treatment, and I think that's as far as clinical care is concerned. But as far as research is concerned, I think it's quite fair to say that it has been lagging quite a bit. And there have not been a lot of high quality studies that have been performed with these individuals addressing these subjects, which is due to a range of different issues. As far as the prospects of doing further research are concerned, I think the potential is immense. And the reason I say that is because now more and more people are getting very used to wearing smartwatches and trackable devices and sleep monitors, which tended not to be the case, let's say, 10 years or 20 years ago. And a lot of them are actually really relying on those activity and sleep monitors to dictate how they lead their lives. That also presents an opportunity to actually assess sleep in real world settings. So there is plenty of data now out there to suggest that actigraphic sleep monitoring, which is using a Fitbit-like device, is very highly correlated with polysomnography or the traditional sleep study. So using those data plus the capacity to study so many individuals across geographical boundaries really allows us to actually delve deeper into the subject. But unfortunately, we have not yet realized that. So I think we're just scratching the tip of the iceberg at this point, but the potential is immense.
Well, thank you so much. So options for people to do research in the future. I wanted to wrap this up by what kind of advice do you have for our listeners, like top 3 things to kind of take away from this podcast?
And I think what I would like most people to understand is that sleep and thyroid function are very tightly related. There are lots of overlapping and interacting fields, and by helping one aspect, you can really help the other aspect. Number 2, it's very important that we set expectations in our patients and we do counsel them appropriately. So, for example, when we are starting somebody on treatment, we can advise that they also implement sleep hygiene measures and keep a low threshold for referring patients for things like obstructive sleep apnea assessment, which tend to be very common. And finally, if there is some suspicion of an underlying primary sleep disorder, as endocrinologists, it is our obligation to refer them soon to a sleep specialist who can adequately assess those issues and treat them. So as long as we detect it, screen for it, and refer these patients out and counsel our patients, I think we'll be doing the best we can.
Thank you. It was an honor to have you join us today to talk about sleep and thyroid. And please stay tuned for upcoming episodes of the Thyroid Stimulating Podcast.